All right. Okay. So the same patient, another case scenario, or the same patient with a moderate to good motor recovery in the lower extremity, that's generally happened to the stroke patient. However, the left upper extremity is still non-functional and has some sensory loss. What rehab treatment available for this patient? So we do know the traditional therapy, right? I know we have been, probably dealing with the stroke patient, but a lot of times you already forget what we're doing. We are now just monitoring INR and to look at the therapeutic range. So we need to know a little bit theory about the therapy. So there's a 4 traditional therapy: brainstorm, neurodevelopmental treatment, proprioceptive, neuromuscular facilitation, and cutaneous sensory stimulation. So in order to answer the questions in your SE and the board, you have to know each individual therapy. What is the theory behind them? So you read about it because for the clinical evidence, the current treatment will focus on different concepts. The common concept behind this traditional therapy are facilitation and inhibition. However, current approach for motor relearning, we focus on functional training, work on specific tasks, and how to functionally attain them. Mental effort, how active the patient participating in the functional task make difference for their neuroplasticity and motor relearning. The reason we don't focus on strengthening of the muscle anymore because it didn't show much evidence behind it. We more focus on functionality task. So in addition to those conventional therapy, I'm going to talk a little bit more about current research on some innovative rehabilitation treatment available for stroke patients. The first well-studied treatment is constraint-induced therapy, and also I'm going to talk a little bit about functional electric stimulation, brain stimulation, and robotic assistive therapy. Constraint-induced therapy. This is the first national prospective, single-blind, randomized, multi-center clinical trial systematically studied the stroke patient population with upper limb weakness, how we're gonna improve the functional for this patient population. So what they do, they're trying to look at the effect of the constraint therapy for 2 weeks treatment to the usual and customary care on improvement in upper extremity function. So this study was published in 2006 in JAMA. The inclusion criteria is the patient suffered the first acute stroke within 3 to 9 months, and they have 2 groups of participants. For higher functioning participants, they have to have greater than 20 degrees of wrist extension, greater than 10 degrees of MCP and IP extension of all digits. And they also are able to repeat movements 3 times in 1 minute. For the lower functioning participants, they have to demonstrate greater than 10 degrees of wrist extension, thumb epiduction extension, and extension in additional 2 digits. They also need be able to maintain the balance while wearing restraint. They are able to independently do the toilet transfers. The patients has cognitive impairment, need to be excluded, and also if the patient unstable medically, had a previous stroke, excessive pain, joints of hemiparetic limb, younger than 18 years old, insufficient stamina, substantial current use of extremity in ADLs, and previous participation in drug or therapy studies. So what they did in the study, the interventional group The patients were admitted on less impaired limb 90% of waking hours and received 6 hours a day interventional treatment for 2 weeks. The structured exercise include adaptive task practice, as we discussed before, is the shaping, and also standard task training, which means continuously activity for 15 to 20 minutes between rest. The control group, on the contrary, only received a Euro and a customary care, which ranged from no treatment to standard PTOT, including exercise, home program, and orthotics treatment, is non-structured. The participants generally have very comparable basic characteristics. They trying to look at the primary outcomes for in terms of the Wolf motor function test and the motor activity log. Wolf motor function test is how much time you perform 15 times and 2 strength tasks. And motor activity log, they use amount of use and quality of movement to measure how well and how often 30 common daily activities are performed. But this is self-rating activity log. As a result, after 2 weeks treatment, as we can see here, the yellow bar are constraint-induced group, which showed much better, requires less time to perform the task, showed a better outcome in terms of Wolf motor function test. In terms of the motor activity log from the patient self-rating, as we can see, regardless of the amount of use and the quality of movement, the interventional group showed much better improvement, higher rating than the control group. And the same thing as a caregiver rating in terms of the motor activity log. In terms of the amount of use and quality of movement, control group showed less beneficial, less rating than the interventional group. In terms of the lower functioning participants and higher functioning participants, they showed a similar efficacy in the interventional groups. And same as motor activity log for both functioning groups. So regardless of the stroke severity, the results are very significant. So the results is very impressive. So in summary, there's a significantly greater improvement post-treatment compared to control on all measures, except there's a one strength test, didn't show much difference. Significantly greater increase in strength of proximal extremity, not the distal, at 12 months follow-up. The number of tasks in Wolf motor function test performed independently with sporadic arm increased 65% from baseline to 12 months follow-up. Both high and low functioning subjects improved more with the interventional group. So, however, there's a limitation regarding this therapy. I know after the study published, everybody in the rehab field were very excited. However, there's issues regarding this clinical trial. In terms of the selection of the patients, actually they screened more than 2,000 patients. Only 10% of them are able to participate. So the generality of the constraint-induced therapy will be a problem. And also compliance of the treatment. The patient has to wear the mitt 90% of the time, waking time. So that's a huge amount of work for the stroke patient population. If the control group received comparable dose of the therapy, what is efficacy? And also for certain bimanual function tasks, the patient will have difficulty, challenge to perform with constraint-induced movement therapy. In order to improve the compliance of the treatment, a lot of clinical trial has been done trying to modify the original protocol of constraint-induced therapy. From the recent meta-analysis, they analyzed the 44 clinical trials involved more than 1,000 patients. Though they still didn't know the optimal dose of the modified constraint-induced movement therapy. So all the studies has variable duration of the therapy, different frequency, and different treatment. However, regardless of the intensity of the treatment, they found there's a significant beneficial effect for motor function of the paretic arm, muscle tone, amount and quality of arm-hand activities based on the self-reported reading in daily living. However, not much significance in terms of the improvement of the quality of life. And also the positive effect was sustained in the long term. So we know the constraint-induced therapy is beneficial. So what drives improvement by this therapy? So the underlying mechanisms are still poorly understood because the intensity and dosing seem like are not the key factors. However, what they found when the patient wear a mitt on the less affected arm without a structured exercise program, like shaping, functional task, treatment, we call the false use therapy, didn't show much beneficial effect. So as a conclusion, as for now, we understand the procedures involving shaping, repetitive exercises, and instruction for behavioral changes are the most important components of constraint-induced motor therapy. So the constraint motor therapy has to combine with the functional task training to see the better outcome. Another innovative treatment currently under research is non-invasive brain stimulation. So different from other type of rehabilitation treatment, working on the peripheral system, increase the neuromuscular recruitment, activation the brain, induce the neuroplasticity. Non-invasive brain stimulation, they trying to direct application of physical modality to the cerebral cortex to enhance stroke recovery. There's the two most common forms. One is the transcranial magnetic stimulation, we call TMS, and another one is transcranial direct current stimulation, TDCS. So neither modality is FDA approved yet, but both are currently being studied off-label. So this is schematic picture of TMS and TDCS. So on the left side is a transcranial magnetic stimulation of the brain using figure 8 coil. On the right side is a transcranial direct current stimulation, TDCS, of the brain with the active electrode anode placed over the primary motor cortex and the reference electrode cathode placed over the contralateral supraorbital region. So the overarching aim of the brain stimulation is based on the theory or the activation pattern after stroke. As I mentioned before, initially after stroke, the contralesional side of the hemisphere will be recruited. Then the activation of the brain will be diminished and the activation will shift back to the injured side. So that's resulting in the motor recovery. Based on this theory, then the non-invasive brain stimulation overarching aim is to modify cortical activities and neuroplasticity by regulating, upregulating the ipsolesional cortical excitability or decrease contralesional cortical excitability. How they achieve this, generally with the low frequency on the left side, the blue electrode, low frequency of repetitive TMS downregulate the cortical activity, or cathode placement on the contralesional side can downregulate the cortical activity. And the high frequency of repetitive TMS will upregulate the cortical activity, the same thing as anode placement on the ipsolesional side. has the same effect for the activation of the cerebral cortex. The reason, because of the persistent hyperactivity of the contralesional hemisphere, will have inhibition to the contralesional site, which can impede the motor recovery. As we can see the other imaging, so we want to promote restoration of the activation of the lesion site and downregulate the contralesional inhibition. So there are several small studies has been done. This is one of the randomized clinical trial compare the active repetitive TMS versus a sham repetitive TMS of the unaffected hemisphere for the chronic stroke patient. They look at the 5 sessions of the repetitive TMS efficacy between these two groups. And the figure is a little bit small, but we can see they trying to look at reaction time, simple reaction time, and also Purdue pegboard test to look at the motor recovery of the two group of people. Then what they found, regardless the other controls, this is the patient population received the repetitive TMS. And the reaction time has much better improvement, and also the simple reaction time has better improvement compared to other control sham stimulation or unaffected limb. And this one's motor function test has better improvement only after 5 sessions of the treatment. And the efficacy maintained after 2 weeks. So currently, there are only small sample sizes clinical trial. The meta-analysis of 50 randomized clinical trials involved 1,000 patients with stroke were found that both TMS and TTCS were effective in improving motor outcomes after stroke. And however, another Cochrane review of 19 randomized controlled trials with a total of 588 patients did not find beneficial effect of repetitive TMS for the treatment of motor dysfunction after stroke, but they saw a positive trend. So with this treatment, we need a larger and homogeneous clinical trial in the future to confirm the results. Robotic assistive therapy. I think a mouse has invested a lot for the robotic assistive therapy. So whether robotic assistive therapy can replace the conventional therapy or show superior efficacy than the conventional therapy is another question we want to answer. So the advantage of robotic assisted therapy are manifold. So they provide greater consistency of the therapy. They can provide higher dose of the intensity and duration of the therapy, as I mentioned before, which are very important for neuroplasticity and motor recovery. And some of the technique can make the portable robotic therapy available for home use. And they rely on the electricity power. They never tired out as a personal physical therapist. And they can incorporate a gaming system to motivate the patient. They can optimize the patient support. Even severely impaired patients are able to move their limbs and able to walk with the robotic assistance. And for the clinical outcome, they can provide more precise assessment. And they're able to provide the therapy under less staff supervision, less one-to-one supervision, potentially in the future can be labor and therapy cost saving. So currently there's 2 types of robotic assisted therapy. One is the end effector devices, work by applying mechanical forces to the distal segments of the limbs. So this type of therapy, generally, patient probably has, lost, not very well controlled the proximal limbs, may at risk of in the bad posture. But exoskeleton type robotic therapy can have the robot axis aligned with the anatomical axis of the wearer to promote better alignment of the upper extremity. There are a lot of research study to clinical trial has been investigated the robotic therapy for upper limb function or gait function. This is one of the clinical trial published in the New England Journal of Medicine in 2010. They're trying to look at the robotic assisted therapy for long-term upper limb impairment after stroke. This is multi-center randomized controlled trial. The intervention they did is they include moderate to severe upper limb impairment patients who suffered stroke greater than 6 months. One group of the patients received intensive robotic assisted therapy. They used the MIT Manus, which is an exoskeleton type of robotic assisted therapy, 36 sessions, 1 hour for 12 weeks. The other group of people received intensive comparison therapy. That's more functionality task specific exercise. Another group of patients only received the Eurocare without any structured exercise. They look at the Fugl-Meyer assessment of sensory motor recovery after stroke at 12 weeks. The secondary outcome, they look at a Wolf motor function test and stroke impact scale. As we can see over here on the left side, when they compared the robotic assisted therapy versus Eurocare, not surprisingly, in most measurements, they showed better outcome with the robotic assisted therapy. However, on the right side, compared to the intensive comparison therapy provided by therapists, they didn't show much more superior efficacy than the conventional therapy. In terms of Wolf motor function test, and they're a little bit inferior efficacy than the intensive comparison therapy treatment. So there's another review article published recently. They look at multiple clinical trial was done with the stroke patients in the subacute or chronic stages. They're trying to compare the robot-assisted therapy to the conventional therapy for the upper limb and hand motor function. As we can see over here, the results are pretty mixed. There's no consensus whether one therapy is superior to another. However, if you combine with the conventional therapy, seems like has beneficial effects than the conventional therapy alone. So in conclusion, at current stage of the recommendation, generally there's very few randomized control trial in acute or subacute stroke patients. Robot-assisted therapy, either end effector or exoskeleton devices for chronic stroke patients, show similar effects relative to conventional therapy. And there's a recent meta-analysis review showed extra session of robotic therapy in addition to the regular conventional therapy are more beneficial than regular conventional therapy alone in motor recovery, especially for the proximal muscle. So in terms of the gait function, whether the robotic assisted therapy provides more beneficial effect on the gait improvement compared to the conventional therapy. There are also a randomized clinical trial published in 2009. They look at the 63 participants with a subacute stroke with an initial walking speed between 0.1 to 0.6 meter per second. Then the participants received 24 one-hour sessions either local mat or conventional gait training. They look at the walking speed and distance using the 6-minute walking test in the mid-session, 12 sessions, or after 24 sessions, and also they look at the long-term efficacy at the 3-month follow-up exam. Surprisingly, what they found, the black bar actually is from the conventional therapy, and the white bar is from the robot-assisted therapy, local mat treatment. So the conclusion we can see, regardless of the speed or distance, actually conventional therapy showed more superior outcome than the robotic-assisted therapy. So the diversity of the conventional gait training intervention appears to be more effective than the robotic-assisted gait training for facilitating returns in walking ability. This is a result from one of the clinical trials. Of course, there's other clinical trials published for the past decades. The review article reviewed most of the robotic-assisted therapy for gait function. Most of the study also done in subacute and chronic stroke patients. And when they concomitant with the conventional therapy, generally they showed more beneficial than the conventional therapy alone. However, the robotic assisted therapy didn't demonstrate more superior than the conventional therapy. So in that case, the conventional therapy cannot be replaced by the robotic-assisted therapy at this current stage. The recommendation generally is that patients receive the locomotor therapy with the use of robotic-assisted gait training combined with the regular physiotherapy showed promising effects on functional and motor outcomes as compared with the regular physiotherapy alone. And the body weight support system generally reserved for patients whose physical condition is too weak to tolerate intense training. So based on the research study, we can see current robotic assisted therapy still has a lot of limitations and issues. They are less flexible than therapists, and also they have risk of obsolescence, and they can be very costly and also space consuming. So the robotic assisted therapy can now replace the conventional therapy as a consensus. However, for the future, clever design with the more computer programming, I think some of the issues will be resolved. The next innovative treatment I would like to discuss is neuromuscular electric stimulation. For some rehab center, they really like the electric stimulation. However, whether there's evidence behind neuromuscular electric stimulation. In terms of neuromuscular electric stimulation, as I mentioned before, for treating post-stroke shoulder pain, they are using the electric stimulation of intact lower motor neuron to cause contraction of the paralyzed operating muscles. There are 3 forms of neuromuscular electric stimulation. One cyclic neuromuscular electric stimulation. Generally, they contract the paralytic muscle at the set duty cycle without any input from the patients. They are passive treatment without any cognitive investment during the process. Another one is the EMG biofeedback mediated neuromuscular electric stimulation. They use partially activated muscle based on the presence of EMG activities or change of joint position. They can contract the muscle, but not strong enough to perform any functional use of the limb. Another one is more advanced, is neuroprosthesis, or we call functional electric stimulation, which can contract the muscle to complete ADLs in mobility task. So based on the neuroplasticity, there's some cognitive investment during the process. So there's theoretically has advantage for motor relearning. This is a small clinical trials They used functional power-assisted functional electric stimulation on hemispastic upper limb to look at the efficacy after once or twice a week, 4 months of treatment, compared the patient only received the regular conventional therapy. So what they do, the patient underwent the electric stimulation on several extensor muscles, ECRL, ECRB, EDC, and EIP. In meantime, they received the motor point blocks on the spastic flexor muscles. Then the patient engaged to the functional activities for 4 months. As a result, the active range of motion of the wrist extension and MP joint was much better improved after functional electric stimulation treatment. They also look at the cerebral blood flow by near-infrared spectroscopy study. What they found at the bottom, you can see there's increased cerebral blood flow in the sensory motor cortex area if the patient received a power-assisted functional electric stimulation. However, if the muscle only received a simple electric stimulation or simple movement, didn't show any cortical activation. There's also functional electric stimulation available for lower limb application. There's 3 FDA-approved transcutaneous peroneal nerve stimulator. I didn't see the application in our rehab floor, but for certain, but for some places they use it quite a lot instead of using the AFO. So as we can see, the design, they have heel switch. When the patient do the heel strike, then they turn on the switch, then the stimulator is on for stimulating the peroneal nerve to assist ankle. Another electric stimulation available is more minimal invasive implantable peroneal nerve stimulator, which is 2-channel. They can stimulate both deep branch and superficial branch of the common peroneal nerve after implantation. So when the foot switch is on, and the patient's ankle dorsiflexion will be assisted, and also the inversion, eversion stability will be promoted. There's a small randomized controlled clinical trial. They look at 29 stroke survivors with a chronic hemiplegia with a foot job. They used the implantable 2-channel peroneal nerve stimulator to correct the foot job. The control group continued to use their conventional walking device consisting of AFO, orthopedic shoes, or no device. They trying to look at the walking speed by 6-minute walk test or 10-meter walkway. So as we can see, in terms of the 6-minute walk test, electric stimulation resulted in 23% improvement of the walking speed. However, the control group only shows 3% of the improvement. The efficacy maintained, and we can see the potential of the improvement in the interventional group. And the efficacy maintained until week 26 compared to other control groups. However, there are still inadequate clinical trials to conclude that neuroprosthesis or functional electric stimulation will facilitate motor relearning, but because of its high functional content, it may ultimately prove to be the most effective approach. The optimal dosing and stimulation remain to be investigated in the larger clinical trial. So future direction. So because there's a lot of research ongoing, a lot of research need to be done. As we can see from all the clinical trial, is still pretty small. sample size in most of the study are done in the chronic and subacute phase. So we promote multimodal combination interventions. The constraint-induced movement therapy can combine with the TMS, or the robot-assisted therapy can combine with the TMS. So those kind of research need to be further investigated. And for the robotics-assisted therapy, we need to develop a training algorithm and smarter programming system to deliver more task-oriented training. So in the future, I think, you know, there's a big hero 6 maybe invented. Okay.
So the mechanism for the transcranial stimulation, is that just improving communication between the two hemispheres? Is that the main way that it works?
Yeah, so when the acute phase after stroke, the hyperexcitability of the contralational side of hemisphere actually is not beneficial. So they can have inhibition. Yeah, that's the reason sometimes we don't promote compensatory movement, because you want the brain restore the function in a proper way. So you want reduce the inhibition, trying to use the affected arm as much as possible and increase the lesional side of the brain activation.
So whether it's like electrical stimulation or magnetic stimulation, it's still sort of quieting down like the hyperactive.
Yeah, they use that theory, you know, just directly application on the cortical surface and modulate the activity.
Also, have you seen any improvement with the acupuncture or the shoulder pain you're talking about? I don't know if anecdotal.
Yeah, the acupuncture, if you with electric stimulation, is pretty similar theoretically with the electric stimulation. Yeah, so it can show some beneficial effect. And although I covered a lot of content, but I didn't go over some other, you know, topics, especially on the left hemisphere stroke. You can have aphasia, dysphagia. You know, there are a lot of rehab topics available. If you guys are looking for or have not decided on the grand round topics, I have tons of topics you can choose from. So this is only scratch the surface, you know, it give you a little bit common scenario, especially for the right hemisphere stroke rehabilitation. Any other questions?